All right, so that first one, I'll take that. That's an easy one. Yes. Just be patient with us. By the end of the conference, I promise you all these slides will be in there for your access. Should you want autograph slides, I believe all the presenters have agreed to a $5 fee per slide collection. Let's take a look. So we've got 2 questions here for Geisinger. So you want to just handle those?
Sure. So
we are looking. Pop your mic's on.
Oh, is it not? Oh,
yeah, no,
yes. Thank you. So we're looking at the acuity. Oh, what's our criteria? We're looking at how sick the patient is. We're looking at are they within 20 miles of our geography, because we didn't want the paramedics spending their time getting to and from the patient. We wanted them with the patient, so that's why we have that limitation in our geographic area. And then the last criteria we're looking at, I'm not sure exactly what I put on the slide. I think that's probably accurate, but we were looking at I'm going to have to check the slide to see what I have on there. A series of conditions that would be amenable to this. So most of them are chronic conditions, but we're looking at the severity of those conditions. So the most common things that we are taking care of include congestive heart failure, COPD. We do some assessments of cellulitis. We don't do a treatment of wound, but we'll do, and some simple pneumonias that we're able to take care of in the home with the support. And do we use any of the peripherals for the ED physician stethoscope, otoscope? Okay, so the most common peripheral, hold on to your seats, is a Bluetooth scale to weigh the patients. That's the most common. We are not using otoscopes and stethoscopes peripherally mounted through using Bluetooth. The paramedics do have stethoscopes and otoscopes with them, but they're reporting that through the video to the physician.
Good. I can tell you that the New Hanover medics do have recordable lung sounds off their stethoscopes, and it gets downloaded into Epic, into all their CP visits, so the physician can actually bring up the lung sounds.
Next grant, we will.
Next grant, yeah. And Dr. Summit, looks like we had a question there for you.
Just by survey, we post visit survey every physician and every EMT. See if they felt like it would go. We also go back and follow up with the patient to see if we were right, if their outcomes eventually. So make sure the patient likes it.
Good. Anybody want to grab those 2 live mics out there and sing us a song or ask a question? You're going to open the door for me to start asking them questions again. There we go. Here's a taker.
Okay, I guess this thing works. Neil Reynolds, University of Maryland, Baltimore. There's a lot of discussion about the potential for fraud with telemedicine. Is anybody aware of any data that's actually reported that there was significant fraud? I think there is a mechanism. I'm standing back farther and farther. It sounds too loud. Anyway, there's both Medicare and Medicaid audit us on routine care of patients, and I would think they could use the same criteria to audit us for telemedicine. And you pointed out the recording, which is a huge thing. And by the way, in the state of Maryland, they haven't allowed us to record our telemedicine. Interesting. So at any rate, is there any data, or are we just being bludgeoned from the payers using this as an excuse?
I do not know of data. I do think that it is the practice of medicine. It's the same standard. You record it in a record. You find the patient, find out what the outcome is. There are processes in place in everyday medicine to look for fraud and abuse, and there's evidence. You're using technology, but how do they know that you really heard what you heard through your stethoscope? You put in your chart what you heard. And every physician that interacts documents a visit. You have also a paramedic who's documenting a visit. You have a patient who was in the visit. So I don't think the potential that concerns me is total strangers calling up or being called by total strangers over the telephone and diagnosing and treating. This is actually the capacity to examine the patient. And I do think that there are ethical concerns, the ability to say, I do not have enough information, you need to bring the patient in, or the doctor has to feel confident in his assessment. But I don't think the potential for fraud is any greater with this than anything else. I think the concern for Medicare, and I can't speak for them, is that you don't have an institution in the home that has quality and safety in it. So I think it ought to be done in the context of a practice. So if I'm a primary care doctor and I have a patient in the home, I should be able to treat this patient, but I'm on the ground if they need me. If the paramedic is there and connects to my office, it should be in the context of that practice. I think there's a lot more potential for fraud in a situation where there's no previously established doctor-patient relationship.
Yeah, I mean, that's a different issue or evolution of the fraud or the mistakes, but our state, the Maryland here, the DHMH is using this as one of their reasons to really control the expansion of telehealth in the state of Maryland. And yet I'm not sure I've seen any data that me as a physician generically is able or is actually doing more fraud by telemedicine rather than face-to-face. So, and you're kind of confirming that at least nobody here is telling me there's any hard data out there. Geisinger, I love it, the way your name has changed to Geisinger. Any rate, for your patients, did you develop any hard physiologic criteria to select, to follow them, such as heart failure with an ejection fraction less than 30, or COPD with an FEV1 less than 800, or real numbers that us docs are kind of used to latching on to?
So as a non-clinician, I can tell you in our proven care initiatives for COPD, for heart failure, a number of other conditions, the specialty will say this is the criteria for selection, and here are the particular pathways. So for example, for heart failure, we know that for ejection fractures, and again, I don't know the numbers because I'm not a clinician, there are certain criteria of how often they need to be calling and a specific group of questions that lead to a decision tree for follow-up, and what that follow-up needs to be by the paramedic, and when they need to go back to either the heart failure coordinator or back to the cardiologist themselves. So we have those algorithms developed. They were developed well ahead of us ever having a mobile health paramedic program. But now, instead of having a nurse, which can be multiple times the salary of a paramedic, doing those questions and answers, we can, now we can have a
cost-effective too.
Right.
Uh-oh.
Now we can have a paramedic doing that, and our nurse navigators love this because now they can spend their time rather than making those calls in reaching out to patients, and we're better using their time as well. So we've got strong advocates from that.
Thank you.
Thank you, Doc. Very good questions. Going once? Going twice? All right, let's talk about security. Is this secure? I'm sitting here thinking we have paramedics in the field right now sending 12 leads via their telephones, their smartphones to ED physicians to try and figure out whether or not this is a STEMI or not, because it's borderline and it's not so easy. You talk to a hospital IT guy and you tell them that that's going on, tears start coming to their eyes. They say, what are you talking about? How can that be going on in today's day and age? Well, it is. So how secure is this? Is this something that is just a no-brainer that, through codecs and jabbers, and this is guaranteed going to be HIPAA happy, so to say? Have you guys heard anything as far as questions on security and transferring of data, whether it be
Our
web-based
transfer
or?
of data is something that it was fundamental to clearance with the IRB. They point blank told us we could not record, that it had to be live streamed. That was part of the HIPAA security and HIPAA privacy. We go so far as to assure that the server that hosts the application resides behind the firewall. The video traffic is encrypted. So the paramedic that takes the picture of a patient, of a trauma patient, and then sends that over a commercial network to the receiving ED hospital, absolutely insecure. Okay? If it's
I know.
Exactly, right?
I'm glad you're here to reinforce it.
Somebody's going to be out there picking that traffic up. They could decrypt that photo, expose someone's identity, and I think those folks and those systems that are performing telemedicine in that way are running a great risk.
So we can't use FaceTime?
Probably not.
Okay.
Or Skype.
Nope.
Or Skype. Why not Skype? That seems to be so popular for meetings now. We can't, I've heard folks say actually Skype should be tied into healthcare some way, somehow. And I said, I'm not an IT guy, but I don't think that's going to work. Yeah, you can't secure that. Anything else you guys want to add as far as security goes? There's some great points. It cannot be recorded. That's a big one.
We can't record, we don't record, and it is completely safe. I mean, it's completely protected.
I think it could vary by jurisdiction where you're doing these types of things, but some of those are federal and they're umbrella and they're overarching, so you need to be compliant, even if your state laws are not quite up to that standard.
So does that come under the FCC? Can it?
I bet.
Yeah, just you hit the nail on the head. Depends upon where you're at. You get outside the areas of D.C., then they absolutely, it's no man's land there, so you'd have to answer to the FCC, which I'm sure is going to be very easy to get them to approve telemedicine or, the equipment that you're using. But I think that's an important question. What do you guys think about the future of these programs? I think every single one of you can say that this telemedicine can absolutely move into a little thing that we call mental health, which I hear that is a huge crisis sitting right behind stroke that we've been ignoring for years. That's probably tied to every bit of medicine that we do. Do you guys think that there's a place for mental health in telemedicine? And I'll double this question up for you. Do you have to have a provider? Should there be a frontline provider with that computer, or is this just something that I can hire some non-medically trained person to go around and do and pop open the box for an examination? So, twofold question. Do you think this can help mental health issues out there and incorporate a mental health piece into all of your patients? And then what are your thoughts on a non-healthcare provider opening that box, so to say, and beginning the process and doing the screening beforehand? Bob, want to lead?
Sure. I know at Allegheny Health Network, we are looking at just that as one of many opportunities for telemedicine, telederm, mental health and so forth. So I know that's coming down our pike for sure. With regards to your second question, I think the worst thing we could do is put the cart before the horse. I think we, as a profession, need to do our due diligence, control this in a very professional and ethical fashion, and not open that door to kiosks or whatever, where you're going to have somebody just pop up and say, come on over, sit down, I'll do a telehealth consult with whomever. I think we need to maintain some level of ethical control and appropriateness about this, because if we let that get out of hand, then I think we'll all go down a road we don't want to go down, and it'll just be the demise of this. I don't see this going away. I don't see telehealth or community paramedicine going away. In fact, I think they're both going to continue to grow. But I think that all of us as professionals within that portion of it need to do what's right and what's best for the patient, and I think that all ties into not opening up so wide.
Yeah, I would definitely agree with you. I think there's tremendous opportunity in the mental health arena. As far as popping open the box, I think there is a place for us to have a tee-up for the actual provider. So, for example, I see some colleagues from an organization I was with before I joined Geisinger. One of the things that we did in that scenario is we had Patients that were about to be discharged, you want to get them in with their primary care physician very quickly. You want to make sure that they're following up. We found that we were able to improve the no-show rate of those patients by doing a teleconnect. We weren't calling that health, but teleconnect situation with a scheduler at the practice that they were going to see. That human interaction and being able to see each other was very helpful in reducing no-show rates. So an introduction to telehealth, popping open the box for that, but you still have to be careful to make sure you have the safeguards in place so people don't step over the line.
I don't think you're going to be, and when it comes to inpatient visits, if you don't do that preliminary building of the relationship, you're not going to uncover the fact that there's 5,000 medications in the room sitting behind them. Whereas you just the box gets popped open, a physician's there, or a nurse practitioner or PA, they do a screen and they miss out on so many key things. Right. So I agree. At least the first interaction absolutely has to have a provider there partnered with the telehealth portion.
I think you'll find that, well, in my previous practice as a field paramedic, we sometimes found that patients and their families were poor historians at best. To actually bring that professional clinician into that setting really can help you drill into the details of the ongoing situation. To address mental health, I know that at UVA, in our telemedicine office, the emergency psych service outpaces any other consultant service at our present moment. And then with popping open the box, the question again, I think you'd see resistance, and this is only my personal opinion, from CMS to fund that and reimburse that kind of encounter, and third-party private insurers would follow that card really quickly, and it would actually be a fundamental block to have that paramedic in the room for any kind of road to reimbursement to even open.
Well, I would say psychiatric telehealth is by far the most common telemedicine in Georgia. Every nursing home in Georgia has a telemedicine unit, and they have psychiatric consultation in the home. And it's well received, and I think good quality. And I had a unit in my office, and we did, at one point, there are 4 internists in my group, 60 psychiatric consultations a month, for which our office could be paid a $30 presentation fee, but the doctor could treat the patient. We used a psychiatry group out of Miami who were licensed in Georgia, and a psychiatry group out of Atlanta that were licensed in Georgia. Georgia rules require those individuals to have an emergency plan. They have to know, the doctor has to know where the patient is, what are the facilities around them, how to refer them. They also have to have an after-hours number that patient can call that psychiatrist if they get in a tight or a knee. They can't just disappear when the machine's turned off. They also prescribe by Georgia rules, because as a primary care doctor, the last thing you need is a consultant telling you what to do because you got enough to do. So they have to take ownership of that patient. They have to document a note. It's very, very well received by patients. Patients liked it. They like coming to my office to see the psychiatrist and not going in the psychiatrist's office. So that was a good thing. A study that I want to do, if anybody got any money out there, is I want to put telemedicine units or telemedicine tablets in police cars when they're called to a scene where somebody may have a psychiatric illness that they can't interpret properly, and just see what we can do. We can raise their skill set, but I think there's a lot of potential for that. So if you got money, call me.
And your opinion on should there be a provider of some sort there?
You know, I'm probably different from those guys, because I think if you take somebody that is not, that you train and you get their skill set up so they train, that a non-medical person, I wouldn't call them a non-medical person, because if you train them, they have some skill. But in Georgia, the presenter does not have to be a licensed person. It can be a CMA. And what we found in nursing homes, quite honestly, is the best technology people were the nursing assistants. I mean, they could run the technology, and the LPNs couldn't figure it out. So I don't have a problem with that. I do think the onus is on the person prescribing or treating. So if I'm the doctor, I want to know the person on the other end knows what they're doing. I get a good quality. It's my license on the line, so I'm holding them accountable. You know, the VA, I think now, and correct me if I'm wrong, does in-home psychiatric treatment. I have a little concern about that because you turn that television off, a lot can happen. I'm not so sure about that. I think there needs to be a person on the other end.
Yes.
That has some responsibility for that visit too.
I guess as far as telepsychiatry, I do know that there are quite a few groups that are doing like outpatient telepsychiatry. I'm not really sure if there's anyone doing it in the acute setting, like in the ED, which would be nice because there are a lot of places in rural area that do not have a psychiatrist that might send that patient home when they actually probably need to be admitted somewhere or what have you. So I do feel that it could have significant value there if it's not being used. I'm not sure if it's being used in the acute setting or not. As far as the second part, I know not necessarily in the pre-hospital setting, but when acute stroke, there are some companies that do have, that do offer telestroke services, and they are using nurses in order to triage because they were getting so many stroke alerts at one time that they needed some assistance on figuring out which one is priority one. And I think in that type of setting that yes, it could definitely be beneficial.
Yeah, I would definitely agree.
Do you know, there was a trial in South Carolina with telepsych in all the emergency rooms. Is anybody here from South Carolina? I think it went, what they were able to do in South Carolina, this was a few years back, is they had a group of psychiatrists who were available to every emergency room. And the emergency room that used their services had to train at least enough nurses so that there was always a nurse on staff that had psychiatric skills. And then the psychiatrist would take responsibility for that patient after they were screened by the emergency room doctor to treat. They'd put them in a secure area for up to 48 hours, and most of those patients were able to go home without being sent on to a facility. But it was funded by some good group, and I think it had a very good outcomes. But I don't know the citations of that.
I'm not surprised because the burden on EDs is strictly because of a backed up system and not having services available. And it's funny that you mentioned that you'd like to see them in the back of police cars. 48% of the mental health population with a serious mental illness will spend their time in jail once in their lifetime, 48%. So if you could just knock that down by 10 to 20%, you're going to be freeing up ED bed space because the juvenile or the penal system, which is actually what backs up our mental health system, because once they activate, and this is across the board all 50 states, once they activate a psychiatric evaluation on somebody who's under custody, a bed gets frozen for them in the state institutions, and it just starts this backup process. So if we could stop that from happening and de-escalate that, then we're going to free up bed space. I want to thank all of our panelists for a fantastic afternoon. And I want to thank you guys for being progressive thinkers in healthcare for your services, whatever you do. I know from experience that we all sharers. We don't want any of you folks to have to go through the pain and suffering that we did to get our programs up and off the ground. We want to see more of this great stuff happen. So please do not hesitate to contact any of the presenters. If you look into their bios, I'm pretty sure you can see their contact information. And we look forward to seeing most of you or all of you maybe tonight at the reception area. And God bless.